Well, welcome everyone to the ECG case for the week of March 25th, 2012. This week we've got a great case, and I would say it used to be kind of a complicated case, but now this has really become a bread and butter case. I've heard that these type of cases are even showing up on the board exam, so this is something that you absolutely have to know. This case was sent to us by good friend Chuck Shepard, who's down in Missouri. He had a 38-year-old man that presented with this 12-lead EKG. Now, the guy was having some symptoms on and off, and I think when this EKG was obtained, he was actually asymptomatic. So the abnormality that you see here in terms of the T waves do not have to be in a patient that is symptomatic. Now, many of you hopefully already know what we're going to talk about. We're going to talk about these biphasic T waves in the mid-precordial leads, and this is something referred to as Wellens syndrome. And in this asymptomatic patient with these biphasic T waves, it predicted what he had at cath, and that was a 95% LAD lesion. So let's talk about Wellen syndrome. And for those of you that don't know about Wellen syndrome, we'll get you caught up with what we all should be knowledgeable about. So this is a condition that was first described by a group of very smart cardiologists back in the early 1980s, and it was named after the senior cardiologist on this paper, Heinz Wellens, who still does a lot of publishing in the electrocardiography journals. And what they described was an electrocardiographic T-wave abnormality primarily present in the mid-precordial leads. So that's leads V2, V3, maybe V4. And generally speaking, you ought to have this abnormality in at least 2 out of those 3 leads. And this T-wave abnormality predicted a critical stenosis in the proximal LAD, right? That's a bad place to have a critical stenosis in that proximal LAD. And no surprise, if you have a critical stenosis in the proximal LAD and you've been having symptoms, whether they're active or very recent, you're going to be at high risk for an anterior wall MI or death. In their EKG report, they actually described 2 T-wave abnormalities. Now, type 1 pattern, we're not going to really spend any time talking about because nobody would miss this. This is a deeply symmetric T-wave inversion in those mid-precordial leads. Nobody's going to miss that. Your computer's going to pick it up. Even a first-year medical student is going to look at that and say, this person's got serious disease in the anterior wall in the LAD. But what I want to focus your attention on is the type 2 pattern. And the reason why we need to talk about the type 2 pattern is because your EKG machine and many other folks out there have a tendency to call this non-specific T-wave abnormality. But it's not non-specific, it's highly specific for that proximal LAD stenosis. It's a biphasic T-wave pattern, and notice you don't really need to have any ST segment elevation or depression. It's primarily, again, just a T-wave abnormality. It leads V2, V3, maybe V4 as well. And what they found was that when these patients presented after an episode of chest pain, the T-wave abnormality would persist even though the patients may have been pain-free. Furthermore, cardiac biomarkers are oftentimes normal, so it does not mean that they've infarcted yet. But if it predicts a critical stenosis in the proximal LAD, it means these patients are going to infarct in a big and bad way. Again, you can't rely on T-wave abnormalities. You can't rely on ST abnormalities. You can't rely on cardiac biomarker abnormalities. It is purely a T-wave abnormality. And like any other proximal LAD occlusion, these patients are best treated in the cath lab. Medical management does not work. So aspirin, lytics, clopidogrel, all those things have really not been shown to work well at all. So forget about medical management. It's not going to work well. They are best treated in the cath lab. Now, these are not necessarily, again, patients that are acutely symptomatic, and they don't necessarily have ST elevation, so they don't need to go to the cath lab right now, 1 o'clock in the morning. But you probably ought to be bringing them in and getting them managed relatively urgently. They ought to probably be going to the cath lab during that hospitalization, not being sent home and told to follow up in a couple of weeks. Because in their original report, what they found is that about 75% of patients, if they didn't get treated invasively, if they were only treated medically or simply not treated at all, 75% went on to have a big anterior MI or die within just a couple of weeks. So they don't need emergent treatment, but they do need urgent treatment. Okay, so let's look at a few more examples just to really hammer home this type 2 Wellens T-wave abnormality. Again, this is a patient right now who's asymptomatic, and you notice this biphasic T-wave abnormality, V2, V3, and V4. Even though the patient's asymptomatic, it predicts that this patient has a proximal LAD occlusion. Here's another patient. Once again, biphasic T-wave abnormality, V2, V3, just a hint of it in V4. Notice you don't have to have ST elevation or depression. This patient had an EKG that was read by the computer as non-specific T-wave abnormality. By the way, the last EKG I just showed you, this one, the computer also read this as non-specific. Your computer is not programmed to pick up Wellens. It's going to call these T-waves non-specific in many cases, so don't rely on your computer. When you see these biphasic T-waves in the mid-precordial leads, you've got to worry. Here's another case. This is even more subtle. It's pretty obvious in V3, but V2, relatively subtle in V4 as well, that biphasic T-wave abnormality. Computer called this non-specific T-wave abnormality. This patient also is pain-free at this moment, and this was actually missed, this case. This patient did go on to have a big anterior MI within a week after the patient was inadvertently sent home. Here's a 49-year-old who came in with chest pain and had a recent negative stress test, and you'll notice V2 looks okay, but V3, there's just a little hint of that biphasic abnormality there, and a little hint of biphasic abnormality out there in V4. Here's the baseline 12 lead, by the way. You'll notice the T waves go nice and upright and down, in contrast to what we're seeing now, where it's just this little biphasic abnormality or terminal T wave inversion. Again, I'm not a great artist, so let me take these two EKGs and put them next to each other. So here's the baseline, and here's what the patient has now. All right, and you'll notice the T waves were pretty nice and normal looking before, and now what do you notice? You see just a little bit of that terminal T wave inversion in lead V3 and also in lead V4. That was actually enough to make the emergency physicians worry. That subtle change made them worry and keep that patient around, even though the patient had a recent negative stress test, and about an hour later during observation, the patient's pain came back. Again, so this patient was asymptomatic at the time of arrival. The patient's pain came back during their ED stay, and so they repeated the 12 lead, and now it's no longer subtle. And now your computer actually picked up the big anterior MI. This patient ended up having a big proximal LAD lesion. Here's an interesting case sent by Jason Mansour, who works down in Fort Lauderdale. He sent this case to me maybe about a year ago, I guess. And this patient has an incomplete right bundle branch block pattern that you notice manifests as that big R wave in lead V1. But that's not really relevant to our case. What he was worried about in this case was the biphasic T wave pattern in V2 and maybe just a hint of it in V3. Very subtle, but it was a great pickup. Here's the baseline 12 lead. Take a look. So the baseline 12 lead doesn't have any biphasicness at all. Just normal looking T wave. There's nothing biphasic about that. And again, let me show you the EKG that he's got now. Here you see that it's become biphasic in V2 and just a hint of it in V3. That was enough to get Jason worried enough about this patient to send him off to cardiology. They took him to the cath lab, and this patient ended up having a 90% proximal LAD lesion. So subtle abnormality, your computer won't pick it up. Many times your consultants won't pick it up. It's something that you need to know about. You need to pick it up. The biphasic T waves in those mid-precordial leads, you've got to worry about it. So that's Wellens syndrome in a nutshell. I hope that was helpful. And until next week, I will talk to you later. Take care.